So good evening, everybody, and thank you very much for our annual ISMO post-ASCO meeting, which Cancer Trials Ireland are delighted to be able to host this year. We have excellent speakers lined up, 8 in total, with a very focused timekeeping and limited number of presentation of slides of talks to be presented by each speaker. We hope you'll find the session enjoyable. I'd like to take this opportunity to welcome Martin Sweeney and our patient partner at Cancer Trials Ireland, who presented at the EUA meeting earlier this year, and Claire Kilty of the Irish Cancer Society, who are critical infrastructure in the lives of Cancer Trials Ireland. And before we go any further, and before I forget, I would like to sincerely thank Claire Hopkins of Cancer Trials Ireland for organising today, for all of the behind the work scenes which have been involved in allowing over 300 people to register for this evening's meeting, which is our highest ever and is a tribute to our organisational skills. So I'll hand over to Linda, to my co-chair. Our co-chairs Linda Corrigan and Michael McCarthy for the session, and thank you very much for joining this evening.
Thanks very much, Seamus. And we're going to kick things off straight away with Dr. Rachel Keogh, who's going to give us an update on lung cancer oncology updates. I just wanted to mention that we will just keep a quick eye on the timing, and at 9 minutes I will give the speakers just a warning that we're approaching the 10-minute mark. Thanks very much, Rachel.
It's maybe done.
Can you guys see that?
Yeah, that's perfect.
So I am Rachel. I am a second-year thoracic oncology fellow here at Hopkins. I came here after completing my SPR in Ireland, and I'm pleased to share that ASCO lung highlights. There were many this year, so it's hard to keep this in under 10 minutes, including 2 plenary sessions, but I'll do my best. So I'm going to touch on 3 main themes for the lung cancer presentations. First is the evolution of VEGF inhibitors 20 years after they were introduced, with the first bispecific antibody showing an overall survival benefit in squamous non-small cell lung cancer with Harmony-6. I'm then going to move on to targeted therapies, where we now are seeing RET inhibitors moving into the adjuvant setting, like with Adora and Alina before. And then I'm going to speak a little bit about ALK-positive non-small cell lung cancer and the CROWN trial, which I think shows that we've truly transformed ALK-positive non-small cell lung cancer for many patients into a chronic disease. And so I've signposted some other interesting abstracts along the way for those that are interested. So Harmony-6 was a randomized phase 3 trial conducted in China that looked at this bispecific antibody ivonescimab plus platinum doublet chemotherapy in patients with squamous non-small cell lung cancer. So why this VEGF PD-1 bispecific? So historically, squamous histology patients were excluded from bevacizumab trials owing to the bleeding risk, especially pulmonary hemorrhage. The dual targeting localizes the antibody into the tumor microenvironment, potentially increasing PD-1 affinity and enhancing anti-tumor immunity, while sparing some of that systemic VEGF-related toxicity that we see with conventional angiogenics. And so ivonescimab has already been approved in China in EGFR mutant non-squamous non-small cell lung cancer after TKI progression, and in PD-L1 positive monotherapy. And so in this study, patients were randomized to receive ivonescimab and chemotherapy versus the PD-1 inhibitor tislelizumab plus chemotherapy for up to 2 years. We previously saw a very impressive progression-free survival benefit with this combination. And in this study, during the plenary session, we saw the first overall survival readout. And so here we see that the combination of ivonescimab plus chemotherapy led to an improvement in overall survival, with a median overall survival of just under 28 months for the ivonescimab and chemotherapy arm versus just under 24 months for the tislelizumab and chemotherapy arm. It's important to note that the follow-up is still relatively short, with a median follow-up of only about 21 months. And so this requires longer follow-up to ensure that this benefit is maintained. But I think the other thing to note is that in patients with PD-L1 negative disease, it seems like these patients derive a significant benefit from the combination of IVO plus chemo, although this was a subgroup analysis that was purely descriptive and not formally powered. In addition to this, as expected, we saw more grade 3 and serious treatment-related adverse events with ivonescimab. But importantly, VEGF-related toxicities were relatively well managed and compared to our conventional antiogenics were relatively low. Some important caveats when interpreting the data from this study include that the protocol excluded patients with major blood vessel invasion, significant cavitation, and significant hemoptysis, all important presentations for our patients with squamous histology. The other important point that was highlighted by Dr. Julie Bramer during her plenary discussion was that patients over the age of 75 were excluded from this study. And so the median age was 64, which is a little bit younger than what we would see here in a Western population. Additionally, the trial was restricted to a Chinese patient population, and so we await the results of phase 3 trials to confirm whether or not this will show the same benefit in a global population. Nevertheless, to conclude, this is the first phase 3 trial showing a significantly prolonged overall survival with the combination of ivonescimab and chemotherapy versus tislelizumab with a relatively well manageable safety profile. And I think we're going to see more and more of these VEGF PD-1 bispecific antibodies. This is the phase 2 Rosetta Lung 02 that was presented by Professor Solange Peters in the rapid oral abstract session. And again, we see impressive anti-tumor activity with this PD-L1 VEGF-A bispecific antibody pumitamig, and this was a global trial. We await further results from this. Moving on now and shifting gears to targeted therapy in the adjuvant space, we saw Libretto 432 trial results readout in the plenary session this year. RET gene fusions are rare. They occur in about 1 to 2% of patients with non-small cell lung cancer. And we already have RET tyrosine kinase inhibitors approved in the metastatic setting with pralsetinib and selpercatinib. However, we are yet to have a RET selective tyrosine kinase inhibitor approved in the adjuvant or early stage setting. Importantly, immunotherapy tends to not work for patients with oncogene-addicted non-small cell lung cancer, including those with RET fusion-positive non-small cell lung cancer. This was a phase 3 trial. It randomized patients with early-stage disease, so stage 1B to 3A, to receive selpercatinib twice daily versus placebo for up to 3 years after curative intent therapy. So most patients had surgery. The treatment duration is still an open question. Here they used up to 3 years like we saw in ADORA, but then Alina looked at 2 years with alectinib. And so this is very much an open question in the field. And so what we saw here at ASCO this year was the first readout of event-free survival. And here we see a very impressive improvement in event-free survival in the stage 2 to 3A population, with a 24-month event-free survival rate of just under 92% in the selpercatinib arm versus 61% in the placebo arm. Again, like with ADORA and Alina, we see a very impressive hazard ratio here of 0.172. The study is still immature in terms of overall survival, so we will await that in the future. In terms of side effects, which are very important in the adjuvant setting, as expected, selpercatinib led to an increase in grade 3 or higher treatment-related adverse events, and 17% of patients had treatment discontinued as a result of this. This was most commonly LFT or abnormalities such as AST and ALT abnormalities. But nevertheless, there were no new safety signals. And so to conclude, in patients with early stage RET fusion positive non-small cell lung cancer, adjuvant selpercatinib led to a significantly improved event-free survival versus placebo, leading to a new standard of care for patients with RET fusion positive disease. Interestingly, we're now seeing these tyrosine kinase inhibitors moving earlier and earlier in the disease course. And so this was a very interesting study that was presented in the oral abstract session of patients with high risk stage 3, so those that are borderline resectable non-small cell lung cancer, looking at neoadjuvant lorlatinib in stage 3 advanced ALK positive non-small cell lung cancer. And here we saw a very impressive pathologic complete response and major pathologic response rate in those patients who underwent surgery. So we're moving these TKIs earlier and earlier in the disease course. And then finally, we had the 7-year readout of the Crown trial, which is a global phase 3 study that evaluates lorlatinib, the 3rd generation tyrosine kinase inhibitor, versus the 1st generation tyrosine kinase inhibitor, crizotinib, in patients with ALK positive non-small cell lung cancer. Patients were permitted to enroll in the study if they had brain mets as long as they were asymptomatic. And the primary endpoint was progression-free survival, with key secondary endpoints being overall survival. This study initially read out in 2020, and at the time, median progression-free survival was not reached. Again, in 2024, a 5-year update was presented at ASCO, and median progression-free survival was still not reached. And here we have the 7-year progression-free survival data presented by Professor Mock in the oral abstract session. Importantly, there are still not enough required events for overall survival readout at this time in this trial. And here we see a staggering improvement in progression-free survival in patients with advanced ALK positive non-small cell lung cancer, with 55% of patients at 7 years progression-free at the time of the presentation. In addition to that, the median progression-free survival is still not reached. And they really highlighted that 2-year mark is the critical time for these patients. So if patients are progression-free and alive at 2 years, the chances that they will, or the probability that they will be progression-free at 7 years is 79%, which I think is a great statistic to be able to provide our patients. In addition to the improvement in progression-free survival, we see this staggering benefit in terms of CNS progression-free survival as well with lorlatinib. And importantly, lorlatinib has a very unique side effect profile, which can be very debilitating for patients. And so we need effective management strategies to try and mitigate this, given patients are going to be on this treatment for quite some time. This includes edema, hypertriglyceridemia, hypercholesterolemia, as well as mood changes. To conclude, first-line lorlatinib provided a sustained long-term progression-free survival benefit in patients with ALK-positive non-small cell lung cancer, truly transforming this into a chronic disease for many of our patients with ALK-positive non-small cell lung cancer. And I think this just highlights where we've come. So this was Profile 1014, which was the phase 3 study that looked at first-generation crizotinib. Here you can see the median progression-free survival was 10 months with crizotinib. And now, 12 years later, our median progression-free survival is still not reached for our ALK-positive non-small cell lung cancer patients on lorlatinib. And so now the field is moving towards trying to identify ways where we can prevent or delay resistance and essentially intercept the disease before it becomes overt progression. This was a pilot study that was led by Dr. Michael Conroy during his time at Hopkins and was presented in the rapid oral abstract session. And this is a pilot project looking at a prophylactic peptide vaccine in advanced ALK-positive non-small cell lung cancer with the goal of delaying or preventing the emergence of resistance mutations. So to conclude, dual VEGF PD-1 bispecific antibodies are here to stay, delivering the first overall survival signal in patients with squamous non-small cell lung cancer. We're seeing these tyrosine kinase inhibitors moving earlier and earlier in the disease course, now with adjuvant selpercatinib, a new standard of care for our patients with RET-positive disease. And the 7-year Crown data confirms that lorlatinib can render ALK-positive non-small cell lung cancer a chronic disease for many of our patients. As we reach maximal potency with these TKIs, the next gains will come from intercepting resistance itself, not just producing better inhibitors. And I just wanted to end there with the importance of comprehensive genomic profiling for our patients with advanced and early stage disease, which has now become not only aspirational, but also evidence-based for all patients with lung cancer. And that's it.
Thank you so much, Rachel. That was a really comprehensive overview and some really impressive data. In the interest of time, we might move on to our next speaker.
Yeah, thanks, Rachel. That was fantastic. And I just for as a point for I've got the chat open in a separate window. So if people have questions and we have time for a question or two at the end, if you could type your questions into the chat, and I'll try and get the questions through. But thank you, Rachel. That was excellent. I think the next speaker is Richard O'Dwyer, who is going to be talking about genitourinary updates.
Oh, thank you. I just want to get my slides up now.
Sorry, I didn't hear that. Are you sharing your own slides, Richard, or would you like that to be done?
I should be able to share my slides.
I think it's difficult to hear the microphone, Richard. I don't know.
Are you able to hear me okay?
That's a bit better.
Yeah, perfect. Apologies now. I'm just going to share this here. Are people able to see this? Can people see my slides?
We can see them now, yeah.
Yeah, perfect.
Thank you.
So good evening, everyone. My name is Richard O'Dwyer. I'm a medical oncologist working in the Mater Hospital. I'm just going to give some geo updates from ASCO 2026. Closures. So there was I suppose a lot of really interesting studies and data that were presented at ASCO this year. There were, I suppose, 3 highlights that I'd like to talk about. 3 very seminal studies, including Proteus, Talipo-3, and also an update on EV302, which I think needs no introduction. Regarding our first study of Proteus, so this is this was perioperative apalutamide and androgen deprivation therapy versus placebo with ADT with radical prostatectomy in high-risk localized or locally advanced prostate cancer. And this was by Kaplan. So regarding the Proteus study, we know that more than half of men undergoing radical prostatectomy with high-risk disease will ultimately relapse. And this really represents a significant unmet need for patients within this population. Regarding current standard of care, that can include radical prostatectomy alone, or also radical radiation with ADT with or without abiraterone. And essentially, Proteus was testing hypothesis that adding perioperative apalutamide to ADT in patients undergoing radical prostatectomy would improve outcomes over ADT alone. And this was the design of the study. So approximately 2,000 patients with high-risk disease are randomized 1-to-1 to receive neoadjuvant apalutamide and ADT versus placebo with ADT, and went on to have a radical prostatectomy. They then continued to have a further 6 cycles of apalutamide or ADT versus placebo ADT. And our primary endpoints included pathological complete response or residual disease, or also metastases-free survival by conventional or PSMA PET imaging. Regarding the inclusion criteria, the patients had to have histologically confirmed adenocarcinoma, be candidates for radical prostatectomy, have high-risk localized prostate cancer, and no evidence of distant metastatic disease by conventional imaging. That was an important point. Of note, N1 disease was allowed, and patients had to be eligible for ADT on the basis of cardiovascular risk and investigator assessments. When we talk about high-risk disease, there are a number of different criteria that we use to assess high risk in NCCN guidelines. So regarding for this study, it was basically looking at, I suppose, core biopsies and essentially looking at the number of cores that had recent 7 disease, and also if there is evidence of higher risk disease within that for symptom sleep and Gleason 9. Regarding the baseline,
would it be possible to speak up a little bit, or maybe check your mic? It's very difficult to hear you. I apologize for interrupting.
Oh, no problem. Can you hear me better now? Apologies. Is that a bit better?
It's a little bit better, I think.
No problem. Okay.
It's a little bit muffled, Richard.
Oh, sure. Well, I'm just going to try and do just for one moment. Apologies.
So you're on statin and BP. What's the name?
For years. Amlodipine and atorvastatin.
Don't look muted there, Richard, but we actually can't hear you at all now.
Are you able to hear me now?
Oh, yes.
Yeah,
That's much better.
Oh,
Thank you.
apologies for that. Sorry. Okay. Are you still able to see my slides?
The slides are gone.
Okay, apologies. I'll just go and reshare that. I'm very sorry about this.
Slides, Richard, would that be easier?
Yeah, it might be easier maybe to do that if that would be okay.
Yeah, that's absolutely no problem.
Great, perfect.
You might just have to guide me to exactly where we were when we switched over. Just see.
Yeah. I think we're just going to go to slide number 9.
Okay. So is it here?
Yeah, that's
Yeah.
perfect.
Okay, and you just say next slide whenever you need.
Yeah, perfect. So we can see this is the baseline characteristics. The median age is approximately 66. A majority of patients had more than greater than Gleason 8 disease, and the median PSA was 14.4. I'll go to the next slide. So the trial met its dual primary endpoints. We can see that with regard to the pathological complete response, approximately 9% of patients had evidence of pathological repeat response, and that was defined as either YPT0 or having less than YPT2 disease with 5 millimeters of residual disease. This is compared to 1% in the placebo arm. I think that's a very interesting outcome and kind of which does warrant further study. With regard to its second dual primary endpoint, metastases-free survival by conventional or PSMA PET imaging, it was shown that there was a 20% reduction in the risk of metastases or death after 1 year of perioperative apalutamide and ADT with prostatectomy. Of note, this was a little bit controversial as patients were initially randomized by conventional imaging. However, PSMA PET imaging was introduced during the course of the trial. And of note, I suppose metastases-free survival by conventional imaging was not significant when it was separately studied in this trial. MFS by conventional imaging is thought to be correlated with overall survival. However, MFS by conventional and PSMA PET imaging is thought, I suppose, to be less correlated with overall survival. You might go on to the next slide, please. Regarding other outcomes to look at, event-free survival and time to first subsequent therapies were also important and clinically meaningful endpoints. So we can see here regarding event-free survival, there was a 29% reduction in the risk of oncologic event or death. And regarding time to first subsequent therapy, there was an increase of nearly 3 years in the treatment-free interval when patients were treated with perioperative apalutamide. Next slide. The adverse events were, I suppose, would be expected. Of note, skin rash was seen in the apalutamide arm, which would be expected. Next bullet point, or next slide. So regarding key takeaways, Proteus was the largest phase 3 trial that was conducted for high-risk localized or locally advanced prostate cancer. It was shown that the addition of perioperative apalutamide to ADT for patients undergoing radical prostatectomy was shown to improve pathological complete response rates and also MFS by conventional and PET imaging. Also, there was a 20% reduction in MFS by conventional or PET imaging or death, and also a 29% reduction in event-free survival or death, and time to next treatment was extended from 41.5 months to 74.2 months. What's the next slide? Regarding the important limitations, initially patients were imaged using conventional imaging only, and patients were enrolled from 2019 to 2022. Importantly, an amendment in 2022 allowed PET PSMA imaging as part of the mets-free survival assessment, which was in keeping with standard of care at the time as the standard of care progressed. The endpoint was amended to reflect this. And as we kind of stated, MFS by PET-PSMA is poorly correlated to overall survival. Of note, the control arm in this study was somewhat controversial, as ADT with radical prostatectomy is not a current standard of care. So I think this was a very interesting study. It was a very important study. I think that there likely is a role for perioperative apalutamide in patients who are going to seek to undergo, I suppose, radical prostatectomy. And it'd be important to discuss this trial with patients and to find its place when we're treating patients. Might go to the next slide, please. The next trial I want to discuss was the TALPRO-3 trial. So this was talazoparib plus enzalutamide compared with placebo plus enzalutamide for the treatment of patients with metastatic castrate-sensitive prostate cancer harboring HRR gene alterations. Next slide. So we know that there's significant data supporting the use of PARP inhibitors in combination with ARPIs and ADT in the management of metastatic prostate cancer. And previous trials have shown efficacy of these combinations in the castrate-resistant setting. So TALPRO-3 was really going to test the hypothesis that adding a PARP inhibitor in the form of talazoparib to enzalutamide and ADT would improve outcomes for patients with homologous recombinant repair gene altered metastatic castrate-sensitive prostate cancer. That's the next slide. So this was the design of the trial. Regarding the key eligibility criteria, patients had to have gene-altered or HRR gene-altered metastatic castrate-sensitive prostate cancer. Metastatic disease had to be confirmed by conventional imaging. And patients were randomized 1-to-1 to talazoparib and enzalutamide or placebo and enzalutamide. Of no prior dose of Taxol for castrate-sensitive disease was not permitted. The primary endpoint was RPFS by investigator assessment, and key secondary endpoint was overall survival. On to our next bullet point. Regarding our baseline characteristics, they were well balanced between both. The median age was approximately 70. We can see that approximately a third of patients had BRCA mutations and the remainder had non-BRCA mutated HRR gene alterations, and the majority of patients had de novo metastatic disease. On to the next slide. Regarding the type of genes which were, I suppose, checked in this panel, as we can see, BRCA2 was present in approximately 30% of patients. ATM mutations were present in another 30% of patients. And the next two most represented included CDK12 and also CHEK2 mutations. Next slide, please. So the study met its primary endpoint of investigator-assessed RPFS. We can see that talazoparib and enzalutamide led to a 52% reduction in the risk of progression or death. On to the next bullet point, or sorry, the next slide, please. RPFS was also checked in BRCA mutated versus non-BRCA mutated subgroups. Historically, we think that really BRCA mutations did most, I suppose, was responsible for most of the effect in these studies. However, there was significantly effect was seen in non-BRCA mutated subgroups. So we can see in patients who had BRCA1 or 2 mutations, our hazard ratio was 0.36, and in the non-BRCA mutated subgroups, the hazard ratio was 0.58. On to the next slide. Also significantly, time to PSA progression. It was shown that treatment with talazoparib and enzalutamide significantly improved time to PSA progression with a hazard ratio of 0.5. On to the next slide, please. A subgroup analysis was carried out, and we can see that overall there was a consistent treatment effect for RPFS was really seen across all pre-specified subgroups. In particular, it was seen in high volume disease, patients with BRCA1, BRCA2 alterations. Go on to the next slide, please. This was an interesting slide. So there was analysis done of RPFS by gene analysis. So as we would expect, BRCA2 mutated patients, the combination of talazoparib and enzalutamide was heavily favored. But also patients with ATM mutations are also seen to derive benefit from the talazoparib combination, as were patients with CDK12 mutations. So the next slide, please. The overall survival remains immature at this point, and we're required to read out further in the future. So the next slide, please. The most common, I suppose, side effects were supposed to be what would be expected, with anemia, fatigue, and neutropenia being the most common side effects that were seen in the combination arm. So the next slide, please. So regarding key takeaways, the addition of talazoparib to enzalutamide and ADT in patients with metastatic hormone-sensitive prostate cancer improves RPFS. And RPFS benefit was seen in patients with BRCA mutations, but also in non-BRCA mutated HRR gene alteration populations, with a hazard ratio in the BRCA mutated population of 0.37 and 0.57 in the non-BRCA mutated populations. Regarding toxicities, anemia, fatigue, and neutropenia were seen in 71, 28, and 27% of patients respectively, and overall survival data is still immature, but this trial does reinforce the role of PARP inhibition in the metastatic hormone-sensitive prostate cancer setting. I think this trial really highlights the importance of early genetic testing for these patients. Onto our next slide, please. So the next trial I was going to talk about was EV302. So this was going to be a 3.5-year follow-up response analysis from the phase 3 EV302 study. Next slide, please. So I suppose EV302 really needs no introduction. It was a practice-changing study in the management of metastatic bladder cancer. Initially presented in 2024, EV-Pembro reduced the risk of death by nearly 50% as opposed to platinum-based chemotherapy, and now has become the standard of care in the management of metastatic bladder cancer, has also been shown to be superior to platinum chemotherapy in the muscle-invasive setting. This presentation was really to look at the 3.5-year follow-up data and response analysis. Next slide, please. So this was the trial design. Patients included were those who had known locally advanced or metastatic urothelial cancer, were going to be eligible for EV-Pembro and also platinum chemotherapy, and had to have a creatinine clearance of 30 mils per minute or over. They were randomized 1-to-1 to receive EV-Pembro or chemotherapy in the form of platinum and gemcitabine for up to 6 cycles. And the dual primary endpoints included PFS and OS. On to the next slide, please. So regarding the updated overall survival data, at 3.5 years, 44% of patients in the EV-Pembro arm were alive versus 24.6% in the chemotherapy arm. So a nearly 50% improvement in patient outcomes. To the next slide, please. Regarding subsequent therapies, as we can see in the EV-Pembro arm, a number of patients did go on to receive platinum-based chemotherapy. And interestingly, approximately 30% or so of patients went on to receive platinum chemotherapy, and the overall response rate was still approximately 20%. And the mean overall survival from subsequent platinum was approximately 10.9 months. In the chemotherapy arm, a significant number of patients did receive immunotherapy in the maintenance setting, and also went on to receive immunotherapy when there was disease progression. The next slide, please. If we look at the objective response rate, we can see the overall response rate in the EV-Pembro arm was 67.5% as opposed to 44.2% in the chemotherapy arm. When we compare complete response rates, it was 30% in the EV-Pembro arm versus 14.5% in the chemotherapy arm. Interestingly, about 10% of patients achieved a CR directly with EV-Pembro, and a further 20% went on to achieve a complete response after initial partial response. On to the next slide, please. This is a slide just looking at the number of patients who remained on treatment. So by 6 months, just over half of patients had still remained on treatment. But if we go to 12 months, that would reduce to 41.8%. So it showed that patients were dropping out of being on treatment due to toxicity issues. Next slide, please. So this just looks at regarding safety and treatment exposure. So if we can see in the first chart, it would show that in the overall population, the median time that patients stayed on EV was 7.1 months and 8.5 months on pembrolizumab. With regards to patients who had a duration of treatment of over 1 year, the median time on EV was 14.5 months and 24 months on Pembro. And then patients who had a duration of treatment of over 2 years, median time on EV was 22 months versus 24.9 months on pembrolizumab. In all three, I suppose, of these groups, the rate of grade 3 toxicities was comparable. It was just over the 50, I suppose, the 57 to 58% mark, showing that toxicities were comparable across all three groups and did not appear to be cumulative. Next slide. So regarding the key takeaways in patients with metastatic bladder cancer, overall survival at 3.5 years was 44% for the EV-Pembro combination versus 24.6% for platinum chemotherapy. 30% of patients achieved a CR in the EV-Pembro arm, with 20% of those achieving a CR after initial partial response. And at 3.5 years, the overall survival for patients achieving complete response was 83.6% for EV Pembro versus 68% for chemotherapy. And in patients who did progress on EV Pembro, platinum chemotherapy showed an overall response rate of approximately 20% and a median overall survival of 10.9 months. And the median duration of treatment for EV was 7.1 months and for Pembro 8.5 months. So really, I suppose this has been a real game changer for the management of metastatic bladder cancer and when we're able to access it for patients. I think some of the key toxicity just to highlight with this combination, of course, be the early skin toxicity and also for some of the later toxicity for EV can include peripheral neuropathy, which I think we're becoming more familiar with now. Next slide. So thank you and apologies for IT issues at the beginning. Thank you so much.
That's great. Thank you very much, Richard. That's a very comprehensive update. Obviously there's a lot of work into it. I guess in the interest of time, again, I think we're already underwater on the schedule, so I think we move straight along. If there's anybody that can deliver highly efficient, rapid education on gastrointestinal cancer, is our next speaker, Dr. Zach Coyne.
Great. Now, can you see that? You can.
We have it, yeah. Thank you.
Okay, I'm going to try the 10 minutes. So I'm going to talk about the GI highlights. So in summary, I'm going to talk a little bit about colon cancer, cholangiocarcinoma, and then the plenary obviously was the most biggest news really from ASCO was the pancreas study. So this was a structured exercise program following adjuvant chemotherapy for colon cancer, a cost utility analysis of the challenge trial. So last year at ASCO, the challenge study was presented for structured exercise program in patients who had colon cancer after adjuvant chemotherapy. And this showed that a randomized trial of 3-year structured exercise program versus just providing health education materials showed a benefit in disease-free survival and overall survival. And this abstract was actually on the cost utility from a public payer perspective over 5 years. So I suppose, is exercise worth the cost? Does adding a structured exercise program give good value over the 5 years? And so what they compared was these two groups of cancer survivors following over 5 years. Group 1 was the structured exercise program who also got the health education booklets versus Group 2, which was the health education booklets only. And how did they judge value? I suppose they looked at extra cost of implementing the exercise program. They looked at quality of life years gained, and cost per health year gained. And I suppose the lower the cost and the better the outcome would be the best. So this is what they kind of showed. So it showed that more life years and qualities were given at a lower cost when using the structured exercise program compared to providing the educational booklets alone. So even though there was this setup cost, the program cost was actually offset by the fewer recurrences over 5 years and actually led to a net year saving of 1,500 Canadian dollars per patient. So you can see there the total cost was 31,000 in the exercise group, and that's across all patients, recurred or not, versus the education, which was 33. There was also a life year gain and also a quality of life year gain also. So this was a dominant result. So we got lower cost and better outcomes with no trade-off versus just providing education alone. And I suppose this is something that we should really think about kind of implementing structurally ourselves. I think it's low-hanging fruit and something we should consider, as this is now a standard recommendation and guidelines for exercise. The second study I looked at was in cholangiocarcinoma, which was the FIGHT 302 study. The FIGHT 302 study was a first-line study of pemigatinib in FGFR rearranged cholangiocarcinoma. And so the standard first-line treatment at the moment is chemoimmunotherapy, and there's an approval for pemigatinib in the second-line setting for FGFR2 rearranged cholangiocarcinoma. There's limited data on kind of first-line studies. So this was a phase 3 open-label randomized study, and if you look there, there was 4,500 patients pre-screened, so a huge amount of patients screened, yet only a smaller number enrolled. And I think this shows the type of disease is aggressive, but also difficulty kind of identifying these fusions. So 160 patients, 67 patients were enrolled, and they were randomized to pemigatinib versus gemcis. And obviously that is not the standard approach now, and the standard of care changed during this trial, and therefore this was actually closed early due to that. But we'll talk about that later. And then crossover was allowed. So the primary endpoint was PFS, and key secondary endpoints were disease control rate, duration of response, overall response, OS, and safety. So this is the PFS curve. So we did see a PFS benefit with pemigatinib of 8.34 months versus 6.8 in the gemcitabine cisplatin arm, with a hazard ratio of 0.58 and a significant p-value. Furthermore, there was a threefold increase in response rates of 47% versus 15.5%, and a significant disease control rate also. So then leading on to overall survival, actually, there was no difference in overall survival. So the median overall survival was 24.4 months versus 25 months. This is likely confounded by the crossover. 80% of patients of the chemotherapy arm later received the FGFR inhibitor. So just kind of to quickly appraise this trial, I suppose the comparator arm of gemcis is now superseded by gemcis durva or pembrolizumab, and this led to early closure, underpoweredness, and also the confounding factor of crossover. So I think the bottom line is that pemigatinib is a potential first-line option in FGFR rearranged and has confirmed activity due to the PFS and the response rate we've seen, but the benefit versus modern chemoimmunotherapy remains unproven. I think it stresses really the importance of early identification of these axonal alterations, which can be difficult to get. And I suppose for select patients who weren't fit for chemo IO or so, this is a potential option and is a well-tolerated treatment. So the final study, and this was the plenary kind of big session discussed by Dr. Walpin, and discussant was familiar with us as well, was Dr. Knox, which was my mentor in Toronto. And I suppose the importance of this study is that we've had a plateau in kind of pancreatic cancer treatment over the last number of years. And along with that, there's a very poor 5-year survival of metastatic disease of 3%. And the OS has kind of been stuck in around a year. My sense of patients that maybe in the west of Ireland or in Ireland, it's probably a lot, the real world data is probably less than that. And then only 50% of patients actually make it to second-line chemo, and with that, they then have a poor PFS and outcomes. So the rationale is that greater than 90% or 95% of pancreas cancer adenocarcinoma will have a RAS mutation, and there's really no major approved drug at the moment. G12C obviously we've seen in lung and some effect in pancreas cancer too, but I mean G12C is seen in about 1% of pancreas cancer. So this is the daraxonrasib, which is an oral RAS(ON) multi-selective inhibitor, and based on phase 1 and 2 data led to the RASolute 302 study. And so what it kind of is, daraxonrasib, and how does it work? Well, it's a RAS(ON) tri-complex inhibitor. And so really what happens is that the daraxonrasib enters the cell and kind of binds to this cyclophilin A, which is like a shepherd kind of molecule, and it kind of creates this binary complex, which then forms a kind of inhibitory tri-complex by binding to RAS(ON) at the GTP(ON) state, and this leads to steric occlusion, or basically it changes conformation and nothing else can kind of bind to it, and therefore you get this decreased signaling kind of downstream. And then obviously from the pan-RAS, it kind of hits multiple RAS targets, both mutant and wild type. So a very exciting and clever drug. So the RASolute 302 was a phase 3 trial designed for patient with metastatic pancreas cancer who had progressed on one prior line of therapy, an ECOG 0 to 1. 500 patients were randomized 1-to-1 to daraxonrasib versus investigator's choice chemotherapy, and they were all kind of appropriate regimens there of gemabraxane, Leary, 5-FU, fluorouracil, FOLFIRINOX, FOLFOX. And this was the first of two OS analysis and was the final PFS analysis. And so there was dual primary endpoints. The first was for the RAS G12 population for OS and PFS by blinded independent central review. And if that was significant, they moved on to OS for the overall population. And if that was significant, moved on to key secondary endpoints. So this is the patient distribution, just to make a note that you can see the chemotherapy arm. There was 252 patients, but only treated 85%. And I suppose this was due to the open label nature of the disease that people probably withdrew due to not getting the study drug. The baseline characteristics kind of well distributed. Just to focus on the bottom there at the RAS mutation. So you can see about 80% had a RAS G12D or V mutation. And then another 15% or so had other RAS G12 mutation. And so only a small percentage really of 8% really had a RAS G13 or Q61 or were wild type. And I think of the those 20 patients on the daraxonrasib, only about 9 were wild type. So this is the kind of overall survival in the RAS G12 population, and there was tears and excitement when this was presented, and I think this is agreeable to that, given what we see. So those curves obviously separate early and stay separated. So we saw an overall survival of 13 months, which was double really the chemotherapy arm of 6.6 months, with a hazard ratio of 0.4 and a significant p-value. So like fairly amazing results for pancreas cancer. This is the overall survival in the overall population, so all of the KRAS mutations and wild type. And similarly, there was an overall survival of 13.2 months versus 6.7 and a hazard ratio of 0.4. The other primary endpoint was progression-free survival, and we saw progression-free survival in the RAS group of 7.3 months versus 3.5 months, once again kind of doubling, and also in the overall group, and we saw a tripling of response rates of 33% versus 11%. This is a tolerated treatment. The median dose intensity was 93% versus the chemo 63 to 95%. The most common greater than 5% treatment-related adverse events was leading to dose reduction was rash and stomatitis, and to discontinuation was only 1.2%, really 2 patients due to a rash and 1 due to elevated liver enzymes. There was sadly one death related to the treatment felt to be pneumonitis. I think these are the standard kind of toxicities that we're very familiar with. So being proactive with rash, diarrhea and stomatitis and nausea, I think we're well able to deal with this. So I think the rash is probably more severe than we're used to with other EGFR inhibitors, but I think this is all something we can certainly manage very well. I think this is kind of an early finish now, but lastly, a very important slide, the patient-reported outcomes. So median time to deterioration months. And you can see there pain in the first green box was 9 months versus 3.8. So this is like not only improving outcomes and survival and more tolerable, but also symptoms for the patient and reflected here. So the bottom line is this is a new standard of care for second-line pancreatic ductal adenocarcinoma. It's doubled OS, better PFS responses and quality of life outcomes. It's the first broad RAS pan-RAS drug to target mutant and wild type, and it's oral therapy, which obviously is very important in Ireland when we're trying to get people in for our day where it's quick and started. So the future really is first-line studies. Some first-line earlier studies have showed single-agent response to this drug 47%, and then combination of chemotherapy up to 58%. And so there's the now ongoing RASolute 303 study, which looks at daraxonrasib versus chemo, daraxonrasib versus chemo. And so you could, I suppose, think about giving a frailer patient just the daraxonrasib on its own versus a more robust patient in combination strategy, and then to expand this to earlier stage and assess resistant mechanisms. And this is just to demonstrate the amount of development going on in RAS inhibitors between the specific alleles versus pan-RAS, so a huge amount of development going on. Thank you very much for your time.
Thanks very much, Zach. I think in the interest, you did a great job for timekeeping, and we probably, in the interest of time, will move on to Dr. Carolyn Lenine, who's joining us from James's and is going to give us an update on breast cancer. Thanks, Carolyn.
Yeah, just 1 second here. Can you hear me okay?
Yeah, we can hear you perfectly.
Okay, 1 second. And can you see my slides?
Yeah.
Oh, brilliant. So hello everyone. Thank you to the organisers for the invitation to speak about the ASCO breast highlights today. So there was a lot of excellent breast presentations this year, but I picked 3 presentations to discuss that I think that are clinically relevant to an Irish audience. So I'll start by discussing the REDUCE clinical trial. Then I will talk about the OPTIMA clinical trial. And then I'll talk about the presentation of the additional endpoints of the Tropion Breast 02 study. So first of all, starting with the REDUCE trial, which was a phase 3 non-inferiority trial of the prevention of symptomatic skeletal events with reduced dose denosumab dose density, so 12 weekly versus 4 weekly. Presented by Roger van Moos and colleagues from the Swiss Cancer Institute. So the current ASCO ESMO standard is denosumab 120 milligrams 4 weekly for bone metastasis. So the primary endpoint of this study was time to first symptomatic skeletal event, which is a clinically relevant endpoint. The secondary endpoints were toxicity, including hypocalcemia and osteonecrosis of the jaw rates, as well as time to first and subsequent skeletal event and overall survival. So patients in the experimental group received induction of 4 doses of denosumab every 4 weeks, followed by the maintenance 12 weekly denosumab 120 milligrams. Calcium and vitamin D was mandatory. The statistical design is outlined here. The 2 arms were very well balanced in terms of characteristics of patients. 57% had breast cancer and 50% had more than 10 lesions in both arms. So this is the primary endpoint, time to first symptomatic skeletal event. As you can see, the results were significant. The median time to first on trial symptomatic skeletal event was 56.6 months in the 4 weekly group and 56.5 months in the 12 weekly group. The median follow-up time was 37 months, supporting the maturity of the data. The secondary endpoints of time to first and subsequent skeletal events was met. In terms of the safety outcomes, overall hypocalcemia incidence and osteonecrosis of the jaw incidence, as well as time to first hypocalcemia event or osteonecrosis event, was lower in the experimental group. Separate analysis for breast cancer versus prostate cancer was not presented, but it's unlikely that this effect would vary by tumor type. So the direct cost comparison, switching to reduce 12 weekly halves the denosumab expenditure per patient, and also would reduce capacity in the day ward. So I think that this study shows that the 12 weekly regimen after an induction phase is a new standard of treatment for patients with bone metastasis from breast cancer, and the authors should be praised for reducing toxicity and cost while maintaining efficacy here. So next then is the OPTIMA phase 3 randomized non-inferiority trial of test-directed chemotherapy in patients with high clinical risk, ER-positive, HER2-negative early breast cancer. This was a pre-planned time-driven analysis presented by Robert Stein and colleagues. So we've all become used to using tumor gene expression tests to assist adjuvant chemotherapy decisions. Their main use is for postmenopausal patients with 0 to 3 involved lymph nodes. Supporting evidence for use in premenopausal patients is mixed, and there is almost no data for patients with higher levels of lymph node involvement. So the OPTIMA trial is a prospective randomized control trial of test-directed versus standard treatments. The 50-gene Prosigna was picked for this study following an analysis of a pilot trial that was carried out in the first instance for feasibility. One of the trial hypotheses was that the number of involved nodes would not affect chemotherapy response for low test scores. A Prosigna risk of recurrence or ROR score cutoff of 60 was used as the upper limit for endocrine therapy alone. Scores above this were categorized as high risk if node negative. So this is the OPTIMA design. They recruited men and women with early breast cancer, aged at least 40 and with 0 to 9 involved lymph nodes. Eligible patients were randomized between the control arm, which consisted of chemotherapy followed by endocrine therapy, and the experimental test-directed arm, where treatment was decided by the 50-gene Prosigna test. Those with their tumor ORR score greater than 60 were assigned the same treatment as the control arm, while those with a lower ORR score received just endocrine therapy. It was a non-inferiority trial. The primary endpoint was invasive breast cancer-free survival. The trial was powered to demonstrate 3% non-inferiority after 5 years. They recruited 4,429 patients from 6 countries between 2017 and 2025. And the key finding of this study is shown here in the Kaplan-Meier curve of the low ORR score group. There's no significant difference between trial arms. Both results were consistent with 2% non-inferiority. So the forest plot here shows the subpopulation with low ORR score tumors. There's no sign of heterogeneity within this group. These are the Kaplan-Meier curves on your right here then, according to the number of involved lymph nodes. So 1 to 3 on the left and 4 to 9 on the right. Again, there's no difference. I do point out that the number of patients in the 4 to 9 node analysis here, as you can see, was quite small. And that was a problem with the study that I'll mention in a little while. Important to note that there was mandated ovarian function suppression for premenopausal women. Overall, I think this study broadens evidence that in that molecularly low risk 40 plus age group patient population, ovarian suppression and aromatase inhibitors are likely just as effective as chemotherapy and less toxicity. However, some uncertainty remains in view of the relatively small key subpopulations and short follow-up in OPTIMA. 2 large trials ongoing could provide independent confirmation of these results, the OFFSET trial in the USA and the OPTIMA Young trial in Europe. These trials are designed to answer the chemotherapy question. However, it's unclear when we'll receive these results. And also just to note in this current study that data surrounding patient compliance with ovarian function suppression on the current study was not yet reported. And then finally, the TROPION-Breast02 study. So this was the first-line Dato-DXd versus chemotherapy in patients with locally recurrent, inoperable, or metastatic triple-negative breast cancer for whom immunotherapy was not an option. And this was the presentation of the additional efficacy endpoints from the study by David Sescon and colleagues. So I'll just remind you of the design of the TROPION-Breast02 study as has been reported previously. So patients were randomized to Dato-DXd 6 mg/kg every 3 weeks against an investigator's choice of chemotherapy. The enrolled population was designed to be representative of the real-world triple-negative breast cancer population, including patients with treatment-free interval of 0 to 6 months who are often excluded from trials. And there was a requirement that immunotherapy was not an option for the patient. So the primary endpoints were progression-free survival and overall survival is noted here. Previously presented results from the TROPION-Breast02 study are summarized here. The first-line use of Dato-DXd showed statistically significant and clinically meaningful improvements in overall survival and progression-free survival. You can see here on the right the progression-free, or on the left, the progression-free survival was improved from 5.6 months to 10.8 months, and overall survival was also improved from 18.7 months to 23.7 months, and so that was 5 months. The objective response rate with Dato-DXd was also more than double that with chemotherapy. But what was presented at ASCO was the following pre-specified secondary endpoints. So time to first subsequent therapy, PFS2, time to second subsequent therapy. So here are the results for the time to first subsequent therapy. As you can see here, the median time to first subsequent therapy was increased from 5.6 months with chemotherapy to 10.9 months with Dato-DXd, reflecting that the prolongation in progression-free survival previously reported translated to a delay in initiation of subsequent therapy. PFS2, which reflects the time to second progression or death, is also prolonged with Dato-DXd versus chemotherapy, with an improvement from 11.8 to 15.6 months here, indicating the efficacy benefits of Dato-DXd in the first line were sustained through PFS2. Finally, time to second subsequent therapy or death. So this time point is also numerically improved in favor of Dato-DXd. So just to note, there was a really great talk at ASCO about the promises and pitfalls of PFS2. which is really worth watching back to have a better understanding of this if anyone missed it. So the PFS2 is not demonstrated to be a surrogate of overall survival for metastatic triple-negative breast cancer, was one of the key takeaways of that talk. And that PFS2 endpoints do not confirm benefit of earlier use of experimental therapy in first line versus later. It's always great to have another drug available to triple-negative breast cancer, and I really hope we have access to this drug in Ireland at some point soon. So that's the end of my talk. Hopefully I was within the 10 minutes.
Thank you, Caroline. That was the most perfect timing yet. We actually have we might have time for one question if anybody has any burning questions. Or else we'll move on to our next speaker. Thank you, Caroline. So our next speaker covering CNS updates from ASCO is Dr. Ronan McLaughlin.
Good evening, everybody. Can you see my slides okay and hear me okay?
Yep, that's great.
Perfect. Thank you very much for the invitation to present the key CNS oncology updates from ASCO 2026. I will keep it very straightforward and hopefully very short and under the 10 minutes. This year's meeting included a number of important studies in glioma, low-grade glioma, and in glioblastoma, ranging from targeted therapies through to optimization of existing treatment approaches. Tonight, I'll focus on 3 studies that I believe are the most clinically relevant for everyday neuro-oncology practice. And these include long-term results from the INDIGO study of vorasidenib in IDH mutant glioma, the MAGMA trial in newly diagnosed glioblastoma, and the Japanese JCOG 1703 study evaluating carmustine waivers. Together, these studies highlight where we are making progress and where major unmet needs remain. The key theme emerging from ASCO 2026 is that biology matters. When treatment is directed against a clear molecular driver, as we've seen in other disease sites, meaningful improvements in outcomes can be achieved. Conversely, unfortunately, attempts to intensify treatment without a strong biological rationale continue to be a struggle in glioblastoma. With that in mind, I will begin with what I consider the most important CNS update from this year's meeting. The INDIGO study has already changed practice and led to the approval of vorasidenib in IDH mutant grade 2 glioma. At ASCO 2026, we saw updated long-term follow-up. What is particularly impressive is that the benefit seen in the original publication continues to be maintained over time. These data demonstrate that the treatment effect is durable rather than transient, and for patients with lower grade glioma, durability is particularly important when given the prolonged natural history of this disease. Here we see progression-free survival with continued follow-up. Median progression-free survival is now over 44 months with vorasidenib. This represents a remarkable duration of disease control for a once-daily oral targeted therapy. Importantly, the curves remain well separated, suggesting sustained benefit over time. For patients, this means more years without tumor progression and more years before requiring further treatment. One of the strengths of the updated analysis is the demonstration that patients remain on treatment for prolonged periods. The median duration of therapy exceeded 3 years. This reflects both efficacy and tolerability. Patients generally remain on therapy because the disease is controlled and side effects are manageable. In a chronic disease such as grade 2 glioma, this is a particularly important observation. This slide reinforces the durability of benefit. Even with longer observation, progression-free survival remains substantially improved. Importantly, there is no evidence that the treatment effect is diminishing with time. This provides clinicians with increasing confidence when discussing long-term expectations with our patients. Perhaps one of the most clinically meaningful endpoints is time to next intervention. Many patients with grade 2 glioma ultimately will require radiation, chemotherapy, or additional surgery. The ability of vorasidenib to delay these interventions is extremely valuable. For younger patients in particular, delaying treatment-associated neurocognitive effects may have major implications on quality of life. This slide demonstrates that tumor shrinkage continues to improve over time. Responses deepen with ongoing treatment. This suggests that prolonged inhibition of mutant IDH continues to exert biological pressure on the tumour. The response pattern is very different from traditional cytotoxic chemotherapies and really reflects the mechanism of targeted therapy excellently. Again, we see that response rates continue to improve with extended follow-up. This reinforces the concept that vorasidenib is not simply stabilizing disease, but producing meaningful anti-tumor activity. For a lower-grade glioma population, these findings are highly encouraging. Long-term safety is critical for a therapy that may be taken for years, and importantly, no new safety signals emerged during extended follow-up. The toxicity profile remains manageable and consistent with previous reports. This is reassuring again for clinicians and patients. In summary, INDIGO represents a major success story in precision neuro-oncology. We have durable disease control, delayed progression, delayed need for further intervention, and an acceptable safety profile. I will now move on to glioblastoma, where unfortunately the story is somewhat different. The MAGMA trial sought to answer an important question. Modifying the timing and duration of temozolomide improve outcomes in newly diagnosed glioblastoma. Despite decades of research, the STOP protocol remains our standard of care. Investigators therefore explored whether early initiation or prolonged administration of temozolomide might improve survival. This slide outlines the study design. Patients were randomized to evaluate neoadjuvant temozolomide before chemotherapy and extended adjuvant temozolomide beyond standard treatment. The trial was ambitious and addressed questions frequently debated in clinical practice. This figure demonstrates the treatment allocation and patient flow. The important point is that this is a well-conducted randomized study capable of answering these clinically relevant questions. Unfortunately, neoadjuvant temozolomide did not improve overall survival. The survival curves are essentially superimposable. This suggests that initiating treatment earlier does not overcome the underlying biology of glioblastoma. Similarly, extending temozolomide beyond 6 cycles failed to improve outcomes. This is important because many clinicians continue extended therapy in selected patients. These data suggest that routine extension is unlikely to provide significant benefit. The overall message from MAGMA is clear. The STOP protocol remains the standard backbone of treatment. Simply increasing exposure to temozolomide does not appear sufficient to improve outcomes. Future advances will likely require biologically informed approaches rather than chemotherapy intensification alone. The final study that I'm going to discuss evaluated carmustine waiver implementation. Historically, this strategy generated considerable interest because it provides local chemotherapy delivery directly into the resection cavity. The question was whether this approach still adds value in an era of increased and improved surgical and radiotherapy techniques with temozolomide. This was a multi-center randomized phase 3 study involving newly diagnosed glioblastoma patients who underwent maximal safe resection. Patients were randomized 1:1 to receive either carmustine waivers followed by standard of care or standard treatment alone. This slide shows patient flow and confirms a robust study design with balanced treatment groups. Importantly, it was powered to detect clinically meaningful differences in outcome. The primary endpoint was overall survival, and although there was numerical separation between the curves, the study failed to demonstrate a statistically significant survival benefit. Therefore, routine use cannot be justified on the basis of these results. Similarly, progression-free survival was not significantly improved. Taken together, the primary and secondary endpoints tell a consistent story. The addition of local chemotherapy does not meaningfully alter outcomes when modern multimodality treatment has already been delivered. Carmustine waivers did not significantly improve outcomes. Standard radiotherapy with concurrent and adjuvant temozolomide remains the standard of care following maximal safe resection. This study helps refine practice and prevents unnecessary treatment escalation. To conclude, vorasidenib represents a genuine success story in IDH mutant glioma and demonstrates the power of precision oncology. In contrast, treatment intensification without a strong biological rationale continues to fall short in glioblastoma. The greatest opportunities in this disease are likely to come from molecularly targeted therapies, vaccine approaches, and innovative clinical trial designs. From an Irish perspective, where are we with regards to the availability and approval of vorasidenib? Well, it is not currently approved, but there is a finance scheme that now has become available, but still costs patients €54,000 per year. Thank you very much for your attention, and I would be happy to take questions.
Thanks very much, Ronan. That was a really clear and comprehensive overview of what's happening in uro-oncology, and I think represents the challenges in that this kind of difficult to treat disease, particularly with the glioblastomas. I think we have time for questions. Does anybody have a question for Ronan?
Did Beaumont have their hand up?
And I see.
I think they're clapping me from the SPRs in the room. That's what's
Miriam
happening.
Miriam Staunton has a question.
Yeah, I was just wondering, you mentioned about a specific vorasidenib having a patient access. Is it a pay patient access that you mentioned?
It is. So I've had discussions to try to, because I think it's a really meaningful, clinically meaningful drug that delays time to the next intervention for patients. We've had a discussion with the company with regards to operating an expanded access program, but they've already submitted to the National Centre for Pharmacoeconomics here for approval. So in response to my pleas, they have actually designed this patient access scheme where if you pay for 1 month, which is €17,000, they will give you 3 months free. So I'm not currently offering that to our patients. I don't think that is fair at all. I will mention it to patients if they ask for it, but I think that the 52,000 or 54,000 a year is a colossal amount to expect someone to pay for a treatment that they could be on for years and without the definitive answer from the government if it's going to be funded here.
Thank you.
I see just a question from Roisin about any trials focusing on supportive care and rehab in uro-oncology.
There was a number of interesting palliative care and supportive care studies, and I probably think this is probably a good opportunity to plug a study that I've designed here since I come back called the Glio Watch study. So we've received funding and ethical approval, and we hope to roll this supportive care initiative out where we're going to monitor remotely our glioblastoma high-grade tumours here in Beaumont. Hopefully we'll be able to roll that out by the end of the summer and start to enroll our patients locally and then maybe expand it. But essentially it's a Glio Watch study where we're going to have a remote device monitoring activity and to monitor biometrics of patients so that we could perhaps observe a deterioration in clinical status before a crisis admission. And I think that hopefully we'll present that at ASCO in time to come.
It's great to hear, and thank you very much. We might move on in the interest of time, and I think we had a bit of a restructure in our schedule, so we were expecting a skin update from Dr. Anna Olsen-Brown. I'm not sure if she's
I'm not sure
online,
she has
Claire.
joined us, Linda. I've just had a little look through the participants.
Okay.
I think it looks like she's been delayed. She did record her presentation, so I can play it as a video. But we won't be able to obviously interact with her. So
well, we can, if we want, we can move on to the next speaker and see if Professor Olsen-Brown joins us, and then if not, we can play the video perhaps at the end.
perfect. That's a good idea.
So I think next we have Martin Sweeney, who's going to give us an update on the PPI research that has been presented at ASCO. So we're really looking forward to hear about that. Thank you, Martin.
I'm sharing on behalf of Martin, so I'll just quickly.
Thanks very much, Linda, and thanks everybody for the opportunity to speak. We were delighted that the poster was presented at ASCO. It's I think Claire is going to put it up on the screen now, but it's just highlighting the great work that's being done between Irish Cancer Society and Cancer Trials Ireland in areas of patient collab in the area of cancer trials. And I know Claire is coming on in a few minutes to talk about that as well. Claire was there. But we were really centrally involved as patients and as members of the Patient Consultants Committee in putting it together. And Emer Mulvaney led on it with great assistance from Claire and Angela and Ken and Seamus and Paul Kelly. But what we really wanted to do was to highlight the benefits of early patient involvement in cancer trials, collaborating with cancer support group like Irish Cancer Society to make sure that cancer trials are relevant and meaningful, and that the involvement of patients is genuine. And that's something we experience very strongly in Cancer Trials Ireland and with the Irish Cancer Society. Just to give you a little bit of a background of what we do, we're patient consultants. That's what we're called in Cancer Trials Ireland, and I think we like that from the word go, because that's the way we are treated, as people who can contribute to discussions about clinical trials, which ones are best for patients or which have the best potential to do good for patients, and encouraging earliest possible involvement in trial development from the patients. And that happens, for example, with the INSPIRE trial, mustn't grasp. And some of the challenges that were highlighted in the poster are also some of the things that we're trying to do as well in the PCC, such as getting more diversity in clinical on our committees, a greater overall understanding and awareness of what cancer trials are and how important they are and how beneficial they are to patients, because a lot of patients don't really get that. And on that point, the Patient Consultants Committee at the moment are just conducting a project, or starting out on a project, looking at language and the way that people understand or don't understand what cancer trials are. And hopefully that will lead to more enrollment and recruitment in trials, more investment in trials, and earlier access to the great medicines that are coming from these trials. Also just want to mention some of the things we do. We collab with our colleagues in the north of Ireland, and I know Anne McBride is on the call, and just want to acknowledge the fantastic recognition she got in the King's birthday honours, and also that we're involved directly in our own patient-led research in Cancer Trials Ireland Consultant Committee. Miriam Staunton did a very comprehensive study into access to our own records, and I was of course really honoured to present on the EAU stage the first PROACT data, with Paul Kelly being the co-chief there as well. And some of the information we got from PROACT fed directly into our own INSPIRE trial, which Cancer Trials Ireland is running into toxicity around SABRE treatment for localized prostate cancer. So the benefits of working together are so important and so valuable from our perspective, and we're greatly encouraged by the highlighting of this poster and the presentation of this poster, and so with that, I'd just like to pass over. I think Claire is Claire. I think Claire Kilty is also on the call, and thanks very much.
I am indeed. Can you see the slide there?
Yes, we can.
Yeah.
I can't seem to see it. Okay, grand. So look, as Martin said, I was at ASCO. I had the fantastic opportunity to attend ASCO in May on behalf of the Irish Cancer Society. And I suppose we were the only patient advocacy organisation to attend. We attended as an exhibitor as part of the ASCO sponsored patient advocacy stand. So this is something that they've been doing for the last couple of years to really encourage patient advocacy groups to attend ASCO. It was very much centred on US-based patient advocacy organisations, but I suppose what we wanted to go was not to highlight Irish Cancer Society to the ASCO community. It was more to highlight our work on patient partnership and the work that we're doing to embed patients as active partners in cancer research and care. We went with our Irish Cancer Society funded patient and partnership lead in Trinity St James's, Grania Smith. And I suppose what we wanted to showcase to the global ASCO community is the value of charities and cancer centres working together to drive patient partnership across clinical cancer pathways. So we also went with our two amazing patient partners, Erin and Linda, to help us exhibit. So Erin and Linda there are on the end of the picture there. As you can see, this was our exhibition stand. And again, it was all about, you know, come to the stand, learn a bit about patient partnership, learn how you can embed patient partnership in clinical cancer care. The brief I was given today was to give the PPI perspective of ASCO. So I asked Erin and Linda for their thoughts as the patient partners. And I suppose overall, they wanted me to highlight what an amazing experience it was for them as patient partners getting to attend. So, you know, Erin's quote was, "As an Irish breast cancer patient and survivor, ASCO made me feel that our lived experience is meaningful. Hearing all the global discussions on research, treatment, and indeed survivorship only reinforced that patient voices are being heard more than ever." So I know she got an awful lot out of it. And then similarly, Linda, who was another patient partner we went with, you know, she added that for research to be truly empowering, patients must be able to understand it. Bridging this gap, moving from clinical jargon to accessible terms, is essential to reduce diagnostic anxiety and improve outcomes. And I could see this change by interacting with clinical researchers at ASCO. So I suppose from my point of view, I'll certainly echo that. There was a real feeling of empowerment in the room. And it was lovely to meet other patient advocates. You know, there was a dedicated patient advocacy room where we got to meet, and there was a number of talks, and we got to meet the ASCO president one-on-one, which was, I know, really important to the patient advocates that were there. And we had so many people coming up to us, a lot of people coming up to us to talk about Ireland. Interesting, there was a lot of, because we were exhibitors, right, they knew that they could come to us and there was someone from Ireland that they could talk to. There was a lot of doctors and clinicians interested in actually wanting to relocate to Ireland, given the situation in US, and asking us what the clinical trials landscape was like and the clinical research and career development landscape was like, which was interesting. A lot of interest in patient partnership, and talking and having conversations about what patient partnership was. I suppose one of my takeaways from it was, I know most of you online today will have had lots of experience going to ASCO, but for someone like me and my PPI partners who don't go to the big conferences, I found the plenary session truly remarkable. It's unlike anything I've ever seen before, even when I was in my own scientific background. I suppose the standing ovation and the genuine emotion in the room, especially during that pancreatic trial presentation, it was really moving. And I suppose what I took away from it is, and some of my patient partners as well, is we often focus quite rightly on what breakthroughs mean for patients, right? But seeing so clearly what it meant for the clinicians in the room, like that they had new possibilities, that there was hope finally to offer after 15 years for pancreatic trials. I think it's something that we don't always get to appreciate, but it's really important for patients to see. So I think that was something that I really took away from it. In terms of our collaboration with Cancer Trials Ireland, it was brilliant to get the opportunity to co-present our poster there on the role of PPI and CTI, and I know Martin's already chatted about it. You know, we had a lot of interesting conversations with researchers interested in CTI approach to patient partnership, particularly around the concept of those patient-led studies and how PPI is embedded in all aspects of the CTI decision making. So no doubt that will hopefully lead to some interesting collaborations. My key takeaways really from ASCO are we're miles ahead when it comes to patient partnership. We are really leading the way. I mean, you can see it from all that Martin presented there. We're leading the way in Ireland around patient partnership in clinical research. I think there's absolutely opportunities for us in this room to leverage that expertise on a global scale. So, you know, as well as the excellent work we do in research and in clinical trials, we should be pitching Ireland for our expert in the area of patient partnership as well, potential collaborators. And I know when it came up a few times in presentations today, Gráinne Smith, the PPI lead for Trinity, and myself attended a number of sessions at ASCO, and you know what was really consistent to see was the consistent emphasis on the use of PROMs, you know, showing really increasing recognition for the outcomes such as quality of life as important as traditional clinical trial and clinical outcome measures. So I mean, it was really great for us to see that that was being captured as focus and from the point of view of a patient organisation. So yeah, look, that was my takeaway. Overall, really inspiring. And as I said, as a patient advocacy organisation, it was a privilege to be there to witness.
That's brilliant. Thank you, Claire and Martin. I think it's becoming more and more obvious across the landscape of cancer therapy in Ireland, both on a policy level and a research level, that the patient voice has a very influential position and role to play. And thank you for all your efforts, and thank you for your presentation. I think next up, I think could we take Professor Olsons-Brown's video, if that would be possible, Claire?
Yeah, absolutely. I can do that. Just before we do that, we might try and get a really quick photo. If I can just everyone put their cameras on just for 1 minute, I'll do a screenshot and then I will play the video if that's okay. We all just quickly look happy to be here. Fantastic.
Should we do a song or?
Yeah, the choreography we learned earlier, Michael. Okay, that's brilliant. We've still got a few people turning their photos on. Okay, perfect. We'll do it now. 1, 2, 3. Perfect. Thank you everyone for indulging me in that. I will do the video now. Okay, actually, I've just run into a problem here. It's not allowing me to share the sound, although it was earlier today. Okay, maybe could we perhaps go on to Seamus, and I can see if I can fix this in the interim, just because there won't be much point me playing the video if we can't hear Anna. So
Right,
if that's all
great.
right.
And so next up is needs no introduction. Professor Seamus O'Reilly is going to talk to us about AI updates from ASCO. Professor O'Reilly.
Thank you. I'll just see if I can share my screen here. Is it visible?
Not yet.
No, I have your slides here as well, Seamus.
Do you want to do my slides?
Yeah, it's absolutely fine.
Thanks very much, everybody, for being here this evening. Next slide. So AI has a growing footprint in healthcare, from biomarker and drug discovery to clinical decision support. At ASCO, there were over 150 abstracts submitted related to this, 5 symposium, as you can see here. And these are 2 excellent articles in the education handbook related to tonight's presentation and this field in general. Next slide. So how do you go bring 150 abstracts into 3? This slide came up on the session after the plenary session related to healthcare delivery by Chris Jackson in New Zealand. And so what I decided to do was to select the abstracts for that I would discuss today on the lens of access to care. I felt this was the most significant challenge for our society at the present time. Next slide. The first talk I picked is reviewed applications, challenges and opportunities of AI in oncology. Next slide. It initially focused on digital pathology and its integration into what we call multimodal AI. So where multiple applications are put together. Here you can see digital pathology, radiology data or genomic data, and clinical trial support. And these are brought into an AI model to use to prognosticate among published studies with long-term follow-up. How does this look in real life? So next slide. So Artera are a company, and they looked at an MMAI a tool to predict clinical outcomes in early stage prostate cancer. They took a group of NRG studies, including biobanks, and you can see some of these studies dates from the early 1990s, looking at a variety of data and image data. And they used this to develop prognostic algorithms with over 5,000 patients and a predictive algorithm with over 3,000 patients. And they next slide. And what they did in this with this data was they showed that short-term androgen deprivation therapy helped some patients but didn't help others. So you can use it to stratify patients into a biomarker that predicts escalation of therapy. And this is an FDA approved and now involved in the FDA. It's now FDA approved and NCCN guideline incorporated. Next slide. They did a similar analysis in patients with breast cancer using the NSABP B20 data sets, dividing into high risk and low risk group. Next slide. to determine chemotherapy benefit, and you can see wide separation of the curves here. So a very clinically relevant tool, similar to Oncotype DX testing. What about studies in Ireland? So how would it fit in with other trials? So next slide. So they've done similar analysis with looking at the TAILOR-X database, which is almost 20 years old now, starting in April. And when we use the TAILOR-X trial, one of the concerns was it predicted early relapse, but what about late relapse? And in hormone-sensitive breast cancer, half the patients will have late relapse, in other words, after 5 years. So it'd be really handy helpful to have a marker that would predict late relapse. At ASCO, 6 studies were presented looking at AI. Next slide. At AI. Leveraging AI to look at TAILOR-X data. But of these presentations, the most exciting ones had been presented already in December. Next slide. And that was in San Antonio, where they looked at multimodal AI interrogation of the TAILOR-X data sets to see if they could look predicting late recurrence, and they were able to. Next slide. This is the M3T score using to predict from a study that started almost 2 decades ago. And here you can see that they were able to predict late recurrence in patients after at least 4.5 years of endocrine therapy. So it'd be really helpful to have this as an adjunct to Oncotype DX testing in our clinics. Next slide. The enzymatic study is associated with ANZUP, and Cancer Trials Ireland were involved in this also. And here they've developed an AI-based pathology classifier to look at enzalutamide treatment in patients who may or may not benefit from escalation. I've picked these because these have allow us to escalate or de-escalate therapy to optimize treatment for patients and to allow space and access to care. Next slide. A theme in all of these studies has been the ethnic diversity of the population. So it is really important that the study that you don't end up with being a victim of the past. And so preserving ancestral diversity in these studies means that their data is valid 20 or 30 years later. And it goes to highlight a lot of the concern about elimination of diversity, equity, and equality in many of the grant applications submitted at the moment, so that they will pass muster, and the legacy that will lead to in 10 or 20 years' time. Next slide. The other thing that is important related to these studies is the issue of biomarker discovery. So in this paper here, they looked at studies, biomarkers related to clinical trials, from pharmaceutical studies. And you can see while there was extensive research, a lot of them were in data silos, and none of them produced a biomarker that, for instance, we can use in immuno-oncology treatment today. The Artera study pooled numerous studies together, and so one wonders with these academic studies if a similar collaborative venture could be used, that the impact would be greater in terms of predictive biomarkers in the future. And I thought the studies in ASCO that were presented really highlighted the need for data sharing rather than data silos in cancer research. Next slide. Access to care isn't just about treatment, but it's also about diagnostics. And we're seeing that in our clinic on a regular basis. Here, AI improves the entire radiology workflow, from acquisition to imaging interpretation. We have a significant shortage of radiologists globally, and there's also concern in radiology about false negative results and false positive results. Next slide. This particularly applies to mammography, where a false positive results leads to recalls, and where false negative results undermine confidence among patients and the public in the system. So this is the Clarity model validated in real-world mammograms, and you can see a lower false negative rate in these studies. And this has been taken further in the EDITH trial in England. In the EDITH trial in England, they're randomizing people getting screening mammograms to 2 radiography readers versus one human radiography reader and one computer. And so the results of this will be very interesting for the future, and the endpoints look at recall rates and false negative rates. Next slide. Further, they've also looked at algorithms to predict people at higher risk of brain mets in metastatic breast cancer. And this is the Brainstorm trial, randomizing people for intensive surveillance versus standard of care. Next slide. The last one then related to artificial intelligence in patients and trainees, particularly related to global practice. Next slide. In this talk, it talked about the limited availability of radiotherapy worldwide. So I think if we think of the standard of care is that 50% of patients with cancer need radiotherapy as part of their care, but only 10 to 40% of patients have access to it in low and middle income countries. So this is the Archery trial. And in the Archery trial, they're looking at AI treatment planning to increase access to care in low and middle income countries. The next slide. This presenter also talked about another study in India, which had been presented at ASCO maybe 5 or 10 years ago, and looking at visual inspection with acetic acid, a community-based study from Tata Memorial Hospital. And that study was positive in terms of predicting cervix cancer in a community. But this study adds further to that, looking at using smartphone assessment and a digital AI tool to increase the sensitivity of the test. Next slide. Where's AI today globally? So here you can see its use in radiology for imaging detection, in radiation oncology, in digital pathology, and in patient-reported outcome measures with digital devices. And we're going to start to see that with the NeoAct trial, which is starting in Ireland later this year, and also in clinical decision support. This presenter also talked about problems. So next slide. He talks about the concern about medical education and deficits in critical thinking and critical evaluation that could occur with the over-reliance on AI technologies. We live in a world where information is easily accessible, but judgment is not. Next slide. Outside of ASCO, this has been articulated in this papal encyclical, which came out during ASCO, where he quotes Plato. The deepest and most important things are learned only after much time and effort by engaging in discussion with others, striking upon ideas and experiences like flint until the spark of understanding is kindled within us. It's a brilliant paper. I don't think I've ever spoke about a papal encyclical at a medical meeting or heard it spoken about, but this was spoken about at other medical conferences that I've been at, and is a phenomenal document. Next slide. The other thing that wasn't discussed at ASCO, but was discussed at the New York Times around the time of ASCO, was the environmental impact of AI. For the global minority, in the New York Times, where a data center was being built in Montana, which is 5,000 acres in size. So on just to contextualize this, on World Cup week, that's 3,500 football pitches. And the concern here is that the area where they're trying to build the data center, there isn't enough water to have a shower and use the dishwasher simultaneously. These data centers are water intense because the chips have a temperature greater than the surface of the sun, and you need pure water to cool them. Next slide. So in this leads to AI toxicity for the global minority, because to have these platforms, you need rare earth metals, and these are mined in other countries and have cancer-causing implications. So I think in my time attending medical meetings, I've only heard one speaker mention about the environmental impact of AI. Next slide. So how do we bring all of these things together and square the circle? 1 in 3 adults now use AI tools for health information. So what does ChatGPT mean for cancer care in Ireland? So you can see on the right-hand side, AI is present throughout the cancer continuum. I haven't talked about palliative medicine, but there was a palliative medicine presentation where it was used for prognostication, and that prognostication related to earlier end-of-life care discussions with families, but also de-escalation of care for patients. And on the left-hand side then is implications in Ireland, public trust, and the concern about misinformation with what we do, and also governance, who's responsible for error. I was at a meeting where AI was being integrated into mammographic assessment in Dublin, and there were 20 legacy platforms that needed to be integrated with it, or that it would need to be integrated with. And we have this major issue in our health systems. AI literacy is now a core professional competency in what we do. And in Ireland, we also need to look at how energy is provided. In Ireland, by 2030, 10% of Ireland's electricity consumption will relate to healthcare data. And the lessons I learned from ASCO are patients need to be central to how we integrate AI into cancer care, because medical trust is a core a source, is a North Star for how we work and how we do cancer research and how we care for people. And the final point is our new electronic health record is a key enabler. I worry that we're going to have multiple electronic health records in different environments rather than one, which will be a key enabler in how we integrate AI into how we work and how we practice. Thanks very much for listening.
Thanks very much, Seamus. And it's really hard to get your head around how practice is going to change over the next number of years with the integration of AI. Does anybody have any quick questions for Professor O'Reilly?
I wonder, Seamus, do you think the days of medical oncologists are limited with AI?
No, I think we will be needed for, first of all, I think there's growing recognition that the biomedicalization of medicine is not good for patients, that our care needs to be more patient-centric. I think the other thing is that while knowledge is going to be very common, judgment is not. 2 weeks ago, a patient came into me in the clinic and said that wanted me to explain something because she said that she had gone through it with ChatGPT and they weren't able to. So could I please help? And I think that will always be there in how we work. But I think AI, in terms of our efficiency of practice and what we can do more efficiently in terms of document preparation and preparing, biomedical writing, etc., is enormous. I think its potential to make things more efficient is huge. I also feel that there's a whole world of real-world data out there that would help our patients in terms of guiding care that is waiting for the new electronic health records, so we can harvest it.
Just if I can ask a quick question, Prof. With regard to the predictive models of treatment response or brain metastases, etc., are the AI, like the underlying nomograms or algorithms, being able to be interpreted by the investigators, or are these black box tools?
So there's a major concern about algorithm integrity, and also the concern that the skill sets to interrogate algorithms is very limited. If you look historically in medicine, the big fraudulent events in breast cancer medicine were related to stem cell transplants in South Africa, and the NSABP trial for breast conservation versus mastectomy, and both of those were discovered by audit. But I think there's so I suspect most people on the call here could have picked that up. I suspect there might be very few people on the call that could pick up an error in an algorithm. The most famous example of this is the Marina disaster, where a hyphen was left out over an epsilon in the code, and the rocket took off and crashed. And so when we talk about seeing algorithm errors, I think that's probably the exemplar of how challenging that is.
And I think, sorry, go ahead, Michael.
Tariq, do you have a question?
I do, yes. Hi, Seamus. Great talk.
Hi, Tariq.
I just wanted to just ask, just in terms of the quite a juxtaposition between AI and environmental sort of impact. And I think you mentioned there was one chat that you'd heard before that had sort of made some background noise. Do you think that will gather momentum as we go along, or do you reckon it won't sort of gain some noise, if you like?
I think it's gaining noise in the United States. So the map I showed is the moratoriums on data centers in the United States. And when I read the New York Times, there were 10% fewer moratoriums than there were when I prepared the talk today. So that's in 2 weeks, 2 to 3 weeks. So it's gaining momentum because people see it's not feasible for them to lead quality of life. For water is a fundamental element in living, and so it's incompatible with that. Montana don't have a moratorium because they want the money from the data centers. So I think that when it affects the global minority, then it will start to have impact. When it affects the global majority, such as the rare earth elements, I think it's less likely to have it. But I think that one of the things we need to do is to put into our healthcare system, environmental guardrails, when we're doing this, and there's been a real lack in the medical literature of any introspection or judgment calls about that, which is disappointing, frankly.
Okay, thanks, James.
Thank you.
Just to say, we do have the video from Anna on the skin cancer updates. We have that available. So maybe we should get on with it.
Do we play that now? Yeah.
Yeah, I wasn't able to fix my issue with sound, but my wonderful colleague Ema is going to play the video. So teamwork makes the dream work, as they say.
Let's pull it up. Yeah. So.
Hi, my name is Anna Olsen-Brown. I'm a medical oncologist with an interest in skin cancers, and I practice down in Cork, both across Cork University Hospitals and UCC. I'm going to talk us through the relevant abstracts that we saw presented at ASCO this year with regards to melanoma. I'm going to specifically talk about the neoadjuvant, adjuvant, and then into the metastatic space, but also update about some other interesting abstracts that might be worth a look. The first study I'm going to talk about is the neoadjuvant ipi-nivo relatlimab combination therapy trial in macroscopic resectable stage 3 and stage 4 melanoma, the NEO-INR phase 2 trial. This is based on the concept from metastatic data that there is triplicate activity in melanoma patients, and the question is, can that be utilised in the neoadjuvant space? So the design of the trial was that patients with resectable macroscopic stage 3 or 4 melanoma received a triplet of ipilimumab 1 milligram per kilogram every 8 weeks, plus nivolumab and relatlimab 480-160 fixed dose combination every 4 weeks, and then they would have surgery 8 weeks from cycle 1, day 1, and then would be stratified by major pathological response and to determine whether they would go on and have further triplicate therapy. And the primary endpoint of this study was major pathological response, which was defined as either complete response, pathological complete response, or near pathological complete response. In this study, 22 patients were registered, 3 were excluded either due to toxicity or a significant radiological response leading to a decision not to proceed with surgery. And the median time from surgery to surgery from registration was 2.4 months, suggesting there wasn't a delay from treatment onto the patient receiving definitive surgery. We saw pathological complete responses in 12 patients, or 63.2% of individuals, and an overall major pathological response, so those including near and pathological complete responses, in 14 patients, so 73.7% of patients. So the majority of patients had either a pathological complete response or near pathological complete response in the cohort, with only 5 experiencing a non-response. Interestingly, that we saw differences in terms of the radiological response versus the pathological response, with a variety here, particularly with a patient showing progressive disease. When that was correlated with the pathological outcomes, actually we saw that imaging and pathological assessments really didn't correlate at all with in this population, with the majority of patients receiving a pathological response out with their imaging response. And I think it's very interesting that the patient that had progressive disease on imaging actually had a pathological complete response. And similarly, those with stable disease had a mix of pathological complete response, near pathological complete response, and then non-response. So I think this really draws into question whether imaging-based analysis is something we should be doing at all in these patients, and how we get around that without having to surgically intervene in the long term is for me a big question. The event-free survival looks positive, but the follow-up is short, and 1 year event-free survival is shown at 95.5% here. Interestingly, there was one death from toxicity, which was a grade 5 myocarditis, and this just shows the event toxicities in a bit more detail. I don't think there's anything here we wouldn't expect to see. These are all toxicities that we're very comfortable with and see not infrequently, but the fact that there were grade 3 and grade 5 toxicities I think is really important, and this was pulled out in the presentation at the conference. So essentially we can see durable and active immunological function from the triplet. The question is whether we need triplet therapy, and also whether we can and somehow stratify the potential benefit gained from the potential risk of toxicity with what would seem to be a pretty toxic treatment. So the conclusion at the conference was that actually that we needed prognostic and predictive biomarkers, mechanisms of resistance, and how to prognosticate and predict predisposition to immune-related adverse events, so that actually we were able to avoid poor outcomes. I think it'd be fair to say that this correlates with the need, with the sort of the evolving data space around the management of immune-related adverse events as well, and the fact that this probably can be optimised in the coming months, which hasn't as yet necessarily been done as standard clinical practice. So in terms of the next study, looking at the Keynote 942 study, I know this isn't a new study and it has been presented previously, but I think the 5-year data is actually very interesting. So this is a individualized neoantigen therapy trial or a vaccine trial with eligibility criteria laid out there, looking at patients who'd had resected stage 3B, C, D or stage 4 disease and complete surgical resection within 13 weeks before the first dose of pembrolizumab, with no evidence of disease at the point of study entry and a performance status of 0 or 1 and tissue availability for NGS. The patients were randomized in a 2-to-1 randomization to ismodiran plus pembrolizumab or pembrolizumab monotherapy. And they continued to 18 doses of pembro and 9 doses of the INT. Primary endpoints here were recurrence-free survival, with secondary endpoints of distant metastatic-free survival and safety. Interestingly, we saw a consistency and a sort of holding of the data that we saw in the preliminary analysis back in 2022. That's borne out into the 5-year analysis with a sustained hazard ratio of 0.51, which I think is really important for us to see. Obviously, we have lots of questions in our patient population around the adjuvant setting at the moment. And so I think an adjuvant trial needs to show longevity of benefit. And that I think is certainly here in the recurrence-free survival data. There's also some data in the distant metastatic-free survival pace that actually is also quite interesting. And this has a better hazard ratio of 0.41, which I think again is important for us to be aware of in the context of the use of single-agent monotherapy in the adjuvant setting. And then thinking about the overall survival, the company is still commenting that this is immature data, but actually that there is a encouraging trend towards improved overall survival with a hazard ratio of 0.47. So I think cautious to not overinterpret this, but interesting again in the context of other adjuvant studies. Safety was as expected. It was very similar, and the INT didn't appear to add particularly anything of concern to the safety data. I think it is important that we're aware of it, and again that there isn't anything that we wouldn't expect to see in a list of patients treated on immunotherapy. Interestingly, they have done some translational work looking at T-cell clonal expansion and whether they get novel clone emergence, and actually seeing that we see that improved with the combination treatment of ICI and INT, and also actually looking at whether the kind of the degree of clonal expansion and that more novel clonal recognition was relevant, and what they saw here was associated with lower recurrence in the combination treated arm, which I think again we would expect, but interesting we can show that translationally. So in conclusion of this study, essentially the 5-year data looks really encouraging. We can see sustained improvements in recurrent-free survival and distant metastatic-free survival, and a trend towards overall survival. We've also got a manageable safety profile where the INT doesn't appear to add a great deal of concern in terms of safety. And also we're seeing good translational data suggesting that we're seeing different velocity and changes within the immune cell repertoire as a result of the INT being present, which I think is interesting and useful for us to know that we see sort of a direct translational capability. So the phase 3 Interpath study, Interpath 001 study, is fully enrolled, and so we will find out going forward how that plays out. But I think this is probably one of the treatment types that we should be thinking about how we're going to potentially culminate into clinical practice, because the pipeline is something that we're going to have to really think about in terms of whether we can deliver this as standard of care. And then the last sort of major abstract that I'm going to discuss is darocertinib plus crizotinib versus investigators' choice as first-line treatment for patients with HLA-A2 negative metastatic uveal melanoma. So this is the Optium 02 trial, and we know that this patient group is a really under-supported group. We have got an evolving number of options in the HLA-A2 positive space. The HLA-A2 negative space is tricky, and obviously we would think about those whether they can have hepatic chemosaturation, but that isn't possible or appropriate for all. And other than that, then patients have got poor responses to ICI. So this study, I think, was looked upon with interest. And essentially, it's an oral targeted PKC inhibitor. And what we saw was that there was some activity. So this is a phase 2/3 multi-center, multi-arm, multi-stage open label study looking at a combination in 2 different doses versus investigator's choice, which could be pembro, ipi-nivo, or dacarbazine. And then the phase 2 looking at the dose selection, which was 300 milligrams of darocertinib and 200 milligrams of crizotinib versus the same investigator's choice trial options. And then the primary endpoint being progression-free survival. Interestingly, we did see differences. So there's a very significant improvement with a hazard ratio of 0.42 in both BICR and investigator assessed patients. Hazard ratio of 0.36 in the investigator arm. However, when you look at the durations of what that means, we're looking at a duration PFS in the investigator assessment of around 6.7 months versus 2.7 months in the control arm. So a significant improvement, but we are still talking in the region of months. So we have to think about how that impacts on our patients in terms of outcome, but absolutely seeing activity here, which is probably the first time we've seen targeted agent activity in this patient group. So a big stride forward. Whether it's optimized or not yet, we need to think about it. This just shows you the waterfall plots, and then the toxicities, which actually were relatively well tolerated. We saw treatment related SAEs leading to withdrawal in about 0.8% of patients, interestingly, versus 5% in the investigator's choice patient group. So I think this is reassuring from a safety data perspective. This just talks a little bit more about the grade 3/4 treatment toxicities related to the combination, and I don't think there's anything here that we wouldn't expect to see. So in summary, this is a clinically meaningful and significantly longer PFS in patients with metastatic uveal melanoma for whom are HLA-A2 negative. However, we are talking still in the region of months, but a significant improvement in that space. So I would say this is the beginnings of a signal that we need to keep an eye on and to work out the right therapeutic indication for these patients. I just wanted to mention 2 other things. So one was about the PRAME-targeted trials, which are very early in development but are showing in phase 1 studies, they're showing some considerable benefit in previously treated both metastatic cutaneous and metastatic uveal melanoma. So that is really interesting to see. And when they looked at the progression pathways following a response, what they're seeing is isolated sites of progression rather than global progression, which again is very interesting. So I think this is a watch this space. And then there was just a few other abstracts which I'm not going to go into, but just worth if you get the opportunity to go and have a look at. So there was a presentation about re-challenging immune checkpoint inhibitors after a major immune-related adverse events, a question that comes up for us all the time. There was a presentation around looking at the immunological determinations of TILs in melanoma, which I thought was very interesting. There was a leptomeningeal CAR-T abstract, which I thought was interesting. And then similarly thinking about the other PRAME targeted options, looking at the IMTAC bredentafusp, which is tebentafusp's cousin and looks interesting and promising in phase 1. There was also 2 studies that I thought were really interesting. One was about the time of day question, looking at checkpoint inhibitors and whether time of day makes a difference. And this study found that time of day didn't make a difference on its own, but actually you could stratify by neutrophil lymphocyte ratio. And that I think is an interesting dynamic to start and just underpinning some of the mechanistic questions. And then there was an adjuvant study looking at 5-year data from an English registry done by the Cambridge team, who actually showed a very small, modest, but very much there overall survival from adjuvant treatment. So these were the other areas that caught my interest. I hope that's been a whistle-stop tour and has been interesting. And I'll hand over to the next presenter.
So thank you to Professor Alton-Brown for that very informative talk. I think we're fresh out of time. We don't have time for the planned discussion panel at the end. Does anybody have any final questions or comments?
Too bad.
Okay, so with that, just a few final remarks. I'd firstly like to thank all the attendees who took the time to dial in this evening. I'd definitely specifically like to thank all the speakers who volunteered their time and expertise to give what I thought was a very balanced and well explained summary of the key breakthroughs at ASCO. It's not easy when you have a busy working week and have to put together a presentation like this. And thank you to all of our speakers who I think did a great job. I would also like to thank very specifically Cancer Trials Ireland and individually Claire Hopkins, who put a huge amount of work in behind the scenes to coordinate the event this evening and organise the speakers and make sure that everything ran on time. And finally to Linda Corrigan, the Secretary of ISMO, who figured out how to put the timers at the top of the screens, which was a revolutionary breakthrough in terms of keeping to time. I think we did very well overall in the timekeeping compared to a lot of conferences. So thank you very much. And hopefully we're in discussions about having a similar event after ESMO this year, but we'll send around a poll to get opinions on that afterwards. And yeah, thank you very much and good evening.